Um, Hello, my name is Greg Mork, and first of all, I'd like to thank the Heartbeat Perfusion and all the organizers of this meeting. It's certainly an honor to speak with this group of people, and I hope you enjoyed this talk. As you can see from the title, it's a little bit of a different twist on ECMO, but it certainly is one of those things that I'm sure have come across some people's minds from time to time. And obviously I am the director of clinical perfusion at Rush University Medical Center, and I am also we also serve as Stroger Hospital, which is right across the street. My slides aren't advancing. There we go. Disclosures. I have no financial disclosures other than the fact that I'm an employee of Rush University Medical Center. For obvious reasons, during this presentation, some of the sensitive pictures and information have been left out, and I'm sure you can understand why based on the topic that I'm going to be discussing today. And just for reference, this is the second time I've given this talk. First time I did it without any slides at all. It really doesn't require slides, but I thought I'd put the slides in there just to keep things organized and keep me on time. It's a very touchy subject, and one that I hope you all find interesting, and certainly something that generates a lot of good discussion in regards to the ethics of ECMO and everything else. As far as what I'm going to talk about, this was an incredibly emotional event for the entire team and family. And, you know, a lot of what I talk about is going to be my perception of everything that went on during this procedure. But I hope I can stay as true to the course of the process as possible. And just as a side note, this was a pre-COVID VV ECMO. So this was long before not long, but it was about 6 months before COVID hit. And we were certainly not at the levels of ECMO that we were during that period of time. And just for reference, Rush is recognized by ELSO as a gold level center of excellence for ECMO in the fields of pediatric ECMO and adult ECMO. Another thing for reference is pre-COVID, our ECMO cases volume was approximately 2 to 5 adult ECMOs in the ICU at any given time. And at that time, it was pretty much a mix of cardiac and respiratory ECMOs. During COVID, however, and this is nothing special and nothing new, everybody jumped up. We were at a low of about 10 ECMOs, and we got as high as 15, 16 ECMOs on each day. And believe me, that was a struggle to get the equipment for that. Post-ECMO, though, post-COVID ECMO, we dropped back down to the 2 to 5 range. And as a matter of fact, right now, we have three ECMO patients on, 2 of them being respiratory and 1 of them being a cardiac patient. Little background information. So 57-year-old male, we place on VV ECMO for severe respiratory distress. Nothing fancy, nothing crazy, but the fact of the matter is he was certainly unable, despite proning and all these other procedures that they tried to try on this patient, they were not able to get him to adequately exchange O2 and thrive. So we ultimately ended up placing him on ECMO. We use a Centromag, Quadrox, coated circuit, not too much different than anybody else. Our go-to cannula for a lot of these cases was the ProTech Duo 29. We have 2 sizes, 29 and 31, but the 29, this patient was not that. He was a relatively, 5'8", about 160 pounds. He wasn't that big of a guy, so we were able to work with the 29 ProTech Duo just fine. It was inserted under fluoroscopy, and the tip of the cannula was just across the pulmonary valve as recommended by the manufacturer. Flows varied from 3.5 to 4 liters. And in a coagulation, we ultimately ended on bivalirudin, but he was started on heparin initially. And this patient was extubated, and he was very much awake, very much talkative, very much aware of everything going on around him. He certainly had some ups and downs during his ECMO run, but for the most part, 80 to 90% of the time, he was very wide awake, and he was just cruising along on ECMO, just as we hope he would. Here's just a slide of the placement of the ProTech Duo cannula. Significant events during this run. Of course, a VV ECMO initiation, that was an obvious point. Total ECMO days, he had 149 days on ECMO. And for the most part, his ECMO days were relatively uneventful. And I know some of these long-term ECMOs, they have all kinds of, they get septic at some point, there'll be issues, they have their ups and downs, they have their wide awake days, and then they have their less wide awake days. But in this patient was very well wide awake just about the whole time he was on ECMO, obviously with the exception of the first couple days when he was a little bit snowed over for the initial procedure. However, he was quickly extubated and woken up, and he was actually thriving just fine on ECMO, and his kidneys were doing fine, liver doing fine. Everything else was 100% fine on this patient. Wean attempts. There were 5 wean attempts, and each wean attempt, the patient quickly desaturated during each attempt. So he just did not want to be weaned from ECMO, and his lungs just would not take over, no matter how much time and how much patience we gave and the medications. We just failed to wean him off an ECMO. And we tried these over several months. As a matter of fact, it was probably more than 5, but there were many attempts made to keep this patient, or to get this patient off ECMO. And unfortunately, all of them failed. Now, this is the hitch that came in with the whole procedure. Due to an undiagnosed and unreversible pathology, all attempts to wean were unsuccessful. And the patient was not a candidate for transplant, so we were stuck between a rock and a hard place with him. This patient would never recover. And we found that out after about 100, I think it was about 85 days, we realized that this patient was not going to recover. And then the complicated decisions started to be talked about. However, we had the eternal hope that at some point some miracle would happen and his lungs would start to recover. However, when we got to about the 120th day, those hopes were quickly diminished, and we realized that this patient would not come off bypass. So what do we do next? Again, this comes in the whole ethics and the problems with, sometimes we put patients on ECMO and sometimes we can't get them off. What do we do? Now, the complicated factor of this, and anybody who's been in an ECMO program, I'm sure you can speak to this. We've had a number of patients that have been on ECMO for 4 months, 6 months, even up to a year. And if you can imagine the toll that takes on the family, and the complicated part was this patient was from a pretty good distance away from Chicago. He was transferred up here to be placed on ECMO. So the logistics. This patient's residence was 75 miles outside of Chicago in a very rural area. In a perfect world, it would have been nice if we could have transferred him to an ECMO center closer to his home, but there was nothing available, nothing even close to the area, and Rush was the closest ECMO center that we had that we could have dealt with. His home was just outside Kankakee, Illinois, and I don't know if anybody's familiar with that section of Illinois, but it's very rural. As a matter of fact, as the story progresses a little bit, when we get to his house, he's got nothing but a cornfield behind his house, and the town that he lives in literally has a population of about 1,000. And again, this was an incredible burden on the family, because they were staying in hotels around the hospital, but obviously cost and all these other things start to build up. So it created somewhat of a complicated situation, and certainly a burdensome situation for his family and loved ones. No ECMO centers, as I said, near Rush. Rush was the closest one. The distance was huge. I mean, for them to drive up, they would stay a few days at a time, and they would take shifts. And we got to know the family pretty well, because literally they're in the hospital almost 24/7. And again, anybody who's been in an ECMO center with these type of long-term ECMO patients can attest to the problems sometimes that causes. They were very quiet, they were very stoic, and they didn't complain about it. But I've seen this a few times with a few of the long-term patients, and it's really tough on them. As a matter of fact, one of the other families that had a patient on ECMO, the daughter was there every day, and they literally have to quit their jobs so they can be by their loved one's side. Now, this is where it gets complicated. The patient's request was to go home, to be with his family, and all he wanted to do was discontinue ECMO therapy. He didn't want to do it at the hospital, and I understand that. He wanted to go home. So what were our options? First option, transfer the patient home. Now, I need to preface what I'm going to say at this point with the fact is, when I heard about all these plans being made for transferring this patient home on ECMO, I said, this is crazy. I mean, and the first option was going to be transfer the patient home, train a family member on the circuit, and this patient would get one circuit. When that circuit went, then that's all, that would be the end of his ECMO run. Now, if you think about the ramifications of doing something like that and all the problems that can happen, I mean, if you can only imagine what happens when a circuit clots, or let's say a line breaks and this patient's at home, it would just be an absolutely terrifying situation. So that option was only briefly thought of and spoken about. And actually, this discussion was being held between the family and the legal department of the hospital. And this discussion went on for about 2 to 3 weeks, I believe it was. The next option was transfer the patient home with an ECMO team and terminally wean the patient at home. This patient was wide awake, and he was adamant about wanting to go home. He didn't want to be on ECMO. He understood the fact that his disease process was irreversible. There was nothing that was going to make his lungs recover from the original insult. And as I said previously, he was not a transplant candidate. So he is literally stuck between a rock and a hard place. So legal discussions took over 2 weeks to determine the most compassionate option that was realistically available. At this point, as I said earlier, I was in complete disagreement with any of these options, even the option of transferring the patient home and terminating his ECMO at home. I just, even up to the point of the day before we did this transfer, I just had terrible feelings about the things that could happen and what it's going to be like and what's going to happen in a procedure like this. And honestly, I've never, ever in my 45 years as a perfusionist, I've never been involved in anything even close to like this. I mean, we've all had OR deaths and we've all seen people pass in the ICU, but never in a million years would I ever thought I would have been involved in something like this. So what happened is, the plan was, after all the legal disclaimers were satisfied by the family and the hospital, the decision was made to transfer the patient home. And so this was brought to me. The team was going to be 3 people, an ECMO specialist, I'm sorry, not an ECMO specialist, the ECMO coordinator, a PA who specializes in ECMO, and then a perfusionist. And again, I took the role as a perfusionist because I just didn't have the heart to ask any of my perfusion team to take place in something or take part in something like this, because I mean, in a way, I sort of disagreed with it even when we started doing it, or even the day before. So I just, with good conscience, I could not ask any of my staff to do something like this, because I thought that was far too much to ask of anybody. Patient's family was to secure a hospital bed at home and an oxygen source. And they did all this. What we did is we secured 2 transport vehicles. One of them was an ambulance, and another one was a big suburbanish large SUV. And in the transport, or in the ambulance, we had a spare circuit and a spare pump and backup equipment just in case anything happened on the ride down. But we had a number of the other supplies that we were going to need, cannulas, and we just brought a whole batch of everything because we had no idea what we're going to need once we get to this patient's house. ECMO support team is consistent of, as I said before, the ECMO coordinator, the PA, and it wasn't a normal PA. This PA has extensive training in ECMO, so this person was very good at managing whatever it is that we needed to do if anything were to arise, either on a trip down or while we were down at this patient's home. And again, the perfusionist was myself. Transfer. Well, we made the plan. We loaded the patient up at 7 a.m. And we departed. Perfusionist, ECMO coordinator, and PA was with the patient. And fortunately, the patient was on a normal ambulance bed. And another fortunate thing is we were using a Centromag, so that has a small footprint. and we were able to fit everybody in the ambulance without any problem. And again, all the other equipment that we potentially might have needed, even some surgical instruments and sutures and all these other, and gloves and gowns and all these other things that we thought we might need, was in the following vehicle. The trip took about 90 minutes, and it was completely without incident. One thing to note is, because of the fact that this patient was so wide awake and so aware of everything that's going on, you would never know that he's getting ready to, terminate himself from ECMO, because he was very upbeat. He was just glad to be going home. And we had a lot of great conversations on the way down, and I had not had that much contact with this patient beforehand. However, I got to know him pretty good on that ride down, and he was a very personable guy, and he just wanted to go home. I mean, that was all he wanted to do, and he was driven to do so, and fortunately he got his wish. The house was a one-story house. Really, it was out in sticks. There was nothing around him. It was literally a one-stoplight town. Ironically, though, there was a bar right next to his house, and believe me, they frequented that bar a lot when we were there. The house, it was a one-story house. We moved the patient in. It was like a ranch house, but they had a deck off the back of the house, 1 or 2 steps up, and it had a nice big sliding door going in through the family room. So what the patient's family had done was they set up the hospital bed in the family room, and it made it really easy for us to get in and out of the house with all the equipment. So that was one of the things that we were very happy. It was far easier than, say, getting up into somebody's condo or having to travel up an elevator or anything else. It was literally straight in and straight out. And the patient was now in his family room, and his bed was set up, and there were some really unique things that happened from this point on. Chairs lined the room. They had chairs, folding chairs. They probably rented them or got them from the local church or something, but they had chairs all the way around the room. And lots of people started to arrive. His family, his brothers, his wife, his grandkids, everybody was there. They also had a huge buffet of food in the adjoining kitchen area. Like, it was kind of like a family room adjoining the kitchen. And they had liquor, they had food. And one of the nice things is they really treated us as part of their family. The conversation was not encumbered whatsoever. I mean, people were talking about everything and anything, and it was a very celebratory type of atmosphere. And we were able to go and partake in the buffet and everything else, and we took shifts watching the ECMO circuit. But it was the kind of situation that honestly, I'd never found myself in something like this before, and things started to click. And I started to see how special it was to give this guy the wishes that he wanted. So the celebration, adults, grandchildren, relatives. At one point, his grandchildren were jumping up and down on his lap, and he had a Protec in, and the Protec was very secure in its location. We never had a problem with his cannulation migrating either in or out or anywhere else. And that's, I guess, the beauty of using a Protec as opposed to one of the dual lumen other types of cannulas. But everybody was there, and his grandkids were there, his brothers, his sisters, everybody, even neighbors were showing up. The one thing that was very subtle, though, hospice was in attendance. They kept an extremely low profile, but they were off in another room, and honestly, I didn't even realize they were there. They kept a very low profile. This is the funny part. Now is when the patient gets to eat whenever he wants to eat. He had burritos, he had stuff from the buffet that they had there, and guess what? He had a number of beers. He was drinking, and why not? This was his celebration, and this was time for him to just let things go. And the funny part about when he got home and he was drinking beer. Obviously, you drink enough beer, you have to go to the bathroom a lot. And, he would, all of a sudden he had to pee, and we would excuse ourselves from the room, let him do it, and come back. And it was happening more and more as the morning rolled on. But it was a very predictable thing, but it was also very heartwarming to see people just forget about everything. His grandchildren played on his lap. So here's when we come to the part that's critical. The room became very quiet, and I had no idea on the logistics and the timing and the planning that had gone into this. I did not know. I didn't even realize hospice was going to be there. But when they showed up, the room just became quiet, and everybody sat down in their chairs around the room, and it became a little bit somber. So here's where we start to wean. As I dropped the flow, the PA gave some Versed and fentanyl. And in this particular patient, even the minimal reductions of flow caused him severe anoxia. So just as soon as I started to drop the flows, the PA administered Versed and some fentanyl, and he was comfortable. Patient was separated from ECMO and decannulated. Again, this was a very somber portion of the day. This was actually in the early or mid-afternoon by the time that this had happened. And this is when hospice started to take over and started, consoling people. And, there was the obvious sadness that took over the room at that point. And even us as the ECMO team, they had embraced us so much as part of their family. I mean, it just put us in a completely different perspective than anything I've ever been in before. Hospice, again, as I said, hospice took over, and there was paperwork and all these other things. But, one of the other things that took place is, as I mentioned, when we weaned the patient off bypass, we had to decannulate him. And fortunately, it was just a single cannula that slipped out. But all I kept thinking about is when that cannula came out, I mean, anybody who's been a perfusionist knows that sometimes when these cannulas come out, either the tip of the cannula flips and shoots some blood here and there, or things happen. And I remember we were so careful, because here we were in a carpeted family room, and the last thing I wanted to do is spill blood on their carpet. But the PA who did the decannulation was extremely careful, and we took huge measures to make sure we didn't spill anything, and we had disposable, the red bags, to put everything almost as soon as it came out of the patient's neck. But we were very careful and very aware of not wanting to make a mess in this patient's house. Final thoughts. Again, I can't overemphasize the fact that I was totally against this whole thing when this plan was kind of shared with me. I just thought, it's one of those situations. ECMO has created a lot of possible ethical questions in how we do it. And the worst case scenario is one of those patients like this one that you put on ECMO and you can never get off, yet he's wide awake and perfectly with it. So what do? He's not a transplant candidate. He's got nowhere to go at this point. So your only option at some point is either to stay on ECMO, and that is not an indefinite answer, but it certainly is not an ideal option. And this patient just had enough. He wanted to go home, and that was it. However, this was probably the most compassionate process I have ever been involved in, because it was that moving of a procedure. And not that I want to do this every day, or not that I suggest or recommend this to anybody else, but in this particular case, and he's a 1 in a million probably, but in this particular case, it was the right thing to do, and he was able to live his life the way he wanted to. He was able to pass away with dignity. And who wants to pass away in an ICU in a sterile environment when you got alarms going off all over the place? He was in his home, and that's where he wanted to go. The patient and family's wishes were honored. Not an easy thing to do, but they were, and we felt a sense of relief once that happened. So the ethics of the whole thing. Just because we can do it, should we? I don't know. That's the big question. Should we have done this? I don't know. I disagreed with it in the beginning, but once it was done, I thought it was the best thing we could have done. In this case, allowing a patient to pass with dignity, with family, and not in an ICU, in my opinion, was the right thing to do. We were all very touched by this, but it was an incredibly tough thing to do. As a matter of fact, even giving this talk is tough for me to do because of how emotional this particular procedure was. So in conclusion, we packed up 2 vehicles, headed back to Rush. The ambulance packed up with all the equipment, and then, you know, most of the people rode in the SUV because it's far more comfortable and it's sitting along the benches on either side of the ambulance. We returned to Rush. We got back about 5 p.m. And I would like to thank you all for your time and allowing me to share this amazing story with you. I'd like to leave you with a little quote. And when I saw this, I thought it really made sense, because I hope to arrive to my death late and in love and a little drunk. And this guy satisfied all those things. Any questions or comments? And that concludes my talk, and I have 4 minutes left. So keep your program on time. And again, I appreciate the opportunity to share this story with you all. Going through the comments. I don't see any questions, but I appreciate your comments. So one of the there's a question here. Could this have been done for a patient with a different socioeconomic status? You know, we have our patients at Rush, we have them from across the board. We have patients that well insured, patients that are not insured, patients from every ethnicity under the sun. And I do not believe that his socioeconomic class had anything to do with it. He was just, as I said before, I think this was a 1 in a million case where here's a patient that for the most part, he was healthy. His lungs were shot and he was not a transplant candidate. And I can't really share all the other specific as to why he was not a transplant candidate, but it's Rush. I don't know if you're familiar with Rush. The way we operate at Rush is that background means absolutely nothing, and I've always been that way my whole life as a perfusionist. I have the option or the good fortune of doing cases across the street over at Stroger Hospital, and those are all self-pay. People can't pay for their health care. So, you know, here at the Illinois Medical District, I don't believe socioeconomic class has anything to do with it. And I could care less who is under the sheets or who is on the other side of the cannulas. Whatever it's going to be, I'm going to deliver the same type of care, whether it's somebody who can afford their health care or not afford their health care, or whatever the circumstances are. I think it's important that we all practice that kind of those kind of ethics as we practice. So somebody mentioned that this was the second time I gave this speech, and the first time I did it without slides, and I had a tough time getting through it, as that person would probably attest to. And I choked up a little bit at the end of this one, but it was it's good to talk about it, because I'm proud to be part of a team that would be so compassionate, that honors a family wishes as we did. I don't see any more questions or comments. Again, thank you very much for allowing me the opportunity. And see, as we here's starting to arrive. You know what? It was not. The question is, when family started to arrive, was there any preparation amongst your team in case someone got aggressively emotional? No, honestly, that was the last thing we thought of, because we had no idea what we were getting into. But it didn't happen. The family was very cordial. Obviously, they were grieving, but it was such an appropriate setting that I don't think we could have asked for a better setting than it was. And it certainly never became uncontrollable. And I believe that's why hospice was there, and they stayed in the background, and they just remained very, very quiet. And I imagine they probably are equipped to step in a case where something might have gotten out of control, but it never happened. So maybe we're lucky, maybe it was blind luck, I'm not sure what it was, but it worked out. And I think my time is just about up. And again, I'd like to thank everybody for allowing me to share this story. And I hope you enjoy the rest of the conference. Okay, you can end.